2 of hematology will be revised today. And what are the major topics we have in Unit 2?
Abnormalities of
RBC abnormalities, morphological abnormalities, then
bleeding or clotting time.
bleeding time, clotting time, okay, hemostasis, then you have coagulation mechanism, then stem cells, stains, then we have one more regarding coagulation, fibrinolytic mechanism, and that's it, inhibition of coagulation. Yeah, that will be under coagulation, only inhibition of coagulation. Then there is one more small topic which we already completed, that is morphologies of all cells, all blood cells. Okay, that's it. These are the major topics, and of course platelets are there. Platelet roles, their properties. Okay, so first we will start with RBC morphologies. So tell me how we classified RBC morphologies.
Shape, size,
Yes.
arrangement,
So RBC morphologies. So whenever you are attempting this question, first write the basic properties. What are the basic properties of RBC?
biconcave shapes,
Biconcave shape, then size
7.2,
2 microns, then what are the others? What? Count. What is the normal count?
normal count
5.5 to 6.5 million cells per cubic millimeter of blood. Then lifespan. Yes. What is the lifespan?
120 days,
120 days. And where they will be destroyed? In the spleen they will be destroyed. Okay. What is the volume of RBC? Can anyone guess? What is the average volume of RBC? Do you study this? What is the average volume of RBC? You already studied it. No. What is the average volume of RBC? See, when I am asking question in a different way, you don't know the answers. What? No, volume means not count. Shall I say the answer? Everyone clap for Keshav. MCV. MCV will give the volume of the RBC. What is the normal volume of RBC? 88 to 92 femtoliters. I clearly said average volume. I didn't say the specific cell volume. So this is average volume. Mean corpuscular volume. Mean means average. Right? What is the average HB in the RBC? Hemoglobin. MCH value. What is the MCH value? 27 to 32 what? Picograms. Then what is the, I forgot one more. What is the normal HB in the RBC? HB content in the RBC. Okay, HB per gram. Okay, per cubic liter of blood. Alright, that will be a 1 drop of blood, not RBC. I understood. So usually for 1 drop of blood, what is the normal HB? 12 to around 14.5 grams per deciliter. Okay, this is the normal hemoglobin per cubic millimeter of blood. Okay, not a single cell, keep in mind. Then, shape abnormalities. Shape abnormalities are called as RBC shape abnormalities are called as yes, poikilocytosis. Poikilocytosis. Whereas size abnormalities, anisocytosis. Anisocytosis. In the question paper, I might ask, discuss in detail about anisocytosis. Then you should write size abnormalities. If I ask poikilocytosis, then you should write shape abnormalities. Got it? Now tell me few shape abnormalities of RBC. Okay, now wait there. Meanwhile, shape abnormalities can be detected by what lab tests? Very good. RDW. Any others? ESR can also determine shape abnormalities. Very good. Peripheral blood smear. Very good. Peripheral blood smear can determine shape abnormalities. Any other? You can also do this one, stainings. Obviously, stainings. Okay? Yeah, after PBS you will go for staining. That depends. Okay? So these are the tests you can perform to identify any shape abnormalities. Now tell me various shapes, abnormal shapes of the RBC. Sickle cell anemia, very good. Then very good. White cell. So white cell is seen in G6PD deficiency. Then acanthocyte. What is the shape of acanthocyte? Amoeba-like shape. This is the acanthocyte. Seen in heavy metal. Okay, I'm writing TB poisoning or lead poisoning. Any more? Spherocytosis. What is spherocytosis? Cell will be in round shape. Rather than biconchave shape, it will be in round, like a ball. This is seen in congenital spherocytosis. Any more? Huh? Ovalo is different. Any other condition for spherocytosis? You know, spherocytosis can also seen in thalassemia. Do I give it this example? Alright. Any more? Next shape abnormalities. Ovalocytes. Ovalocytes are seen in thalassemia. Very good. Thalassemia, ovalocyte. Then? And also HDN. Very good. What is the full form of HDN? Hemolytic disease of newborn. Then there is one more cell called target cell. Am I correct? Target cell. Target cell is seen in okay. Obstructive liver diseases. So this is called target cell. Iron deficiency. Iron deficiency then thalassemia. Thalassemia. Post-splenectomy. Splenectomy. That means after we got a patient, we remove the spleen. In such patients, we will see target cells. Any other cells we discussed? Stomatocytes. I'm sorry, students. This is stomatocyte. This is not target cell. What is the shape of target cell? Yes, hollow shape. Okay. So target cell will have this mouth-like structure. Stomatocyte. Correct. Okay. Stomatocyte will have mouth-like structure. So stomatocyte is seen in yes, severe alcoholism. Any more? And liver failure. In liver failure and severe alcoholism, we will see stomatocytes. Any others? Blister cell means you will see bleached cell. Some of the discoloration can be seen in the RBC. This is called as a blister cell. Blister cell is seen in microangiopathic conditions. Microangiopathic condition. That means the smallest blood vessels will be blocked by RBCs. This is called microangiopathy. Anyway, any others? Horn cells. Very good. Horn cells are seen in liver disorders. Okay. Horn cells are seen in liver disorders. Okay. Any other cells we discussed? Cystocytes. Very good. Cystocytes looks like this. Cystocytes are seen in DIC, designated intravascular coagulation. And I said one more thing. Microangiopathic condition and also heavy metal poisoning. Very good. Heavy metal poisoning. In this condition, we will see cystocytic cells. Okay, cystocytes means they resembles like malaria parasites. Okay, they are called as cystocyte cells. Any others? No, sir. That's it, right? So these are the various shape abnormalities of the RBC. Actually, I didn't ask you this in 5 marks question, but this will come in 5 marks in the final paper. Okay. So this is the shape abnormalities collectively called as pychylocytosis. Is it clear? Then size abnormalities. Size abnormalities, how we will detect? What lab diagnosis? Yes. Size, MCV, any others? Size abnormalities? Any others? By the way, here I will write one more lab test. Electrophoresis. Electrophoretic separation can able to determine shape abnormalities. Just like electrophoresis there. Yes. Tell me here. Lab diagnosis to detect size abnormalities. MCV and size abnormalities. PBS you can perform. In PBS you can cross, you can see the difference between cross cells. There will be some normal cells and there will be abnormal. Abnormal, obviously you can identify the variation. So in such a way you can detect in PBS. Any more? Any others to determine? Yes sir. Okay. If the cell is large, the sedimentation will be slow down. Okay, it will be slow. If the cell is small, sedimentation will be fast. Got it? Volume. So ESR can be done. Alright. So this is all about size variations. Now increased size is called as what anemia? Macrocytic anemia. Macrocytic anemia. And decreased size is called as microcytic anemia. Very good. Microcytic anemia. Can anyone say examples of increased condition? Macrocytic is seen in vitamin B12 deficiency, folic acid deficiency, and alcoholism. Very good. Alcoholism results in macrocytic. Then microcytic conditions. Iron deficiency. Very good. Thalassemia. Very good. Sickle cell. Crohn's disease. Can anyone say what is Crohn's disease? Okay. That is called as intestinal inflammation. That is also called as inflammatory bowel disease. Inflammatory bowel disease. What happens in this condition? Why inflammatory bowel disease resulted in iron deficiency and microcytic? Inflammatory bowel disease. Bowel movement. You know that intestinal bowel movement. That movement also called as peristaltic movement. Anyway, I cannot the digestive system now. Yes. What contributes to this one? Why inflammatory bowel disease results in microcytic anemia? How intestine related to blood issues? You forgot. Intrinsic factor of, still you are unable to say. Casil. Intrinsic factor of Casil. Alright, listen. So, there is E. coli in the gut. This is gut. This is E. coli. And now you took some vitamin B12. You took some diet. Okay. Now this gut E. coli will make a enzyme called intrinsic factor of Casil. This enzyme will transport vitamin B12 created by E. coli into the system. Okay. Without intrinsic factor of Casil, we cannot reabsorb the vitamin B12. Vitamin B12 reabsorption only happens in the presence of intrinsic factor of Casil. And that enzyme has been produced by intestine. If the intestine wall destroyed, this enzyme will be destroyed. No enzyme, no reabsorption of the vitamin B12. Results in anemia condition. See everything connected? Okay, that's it. Then what else we discussed in size abnormalities? Okay, I discussed various conditions of macrocytic and microcytic. So microcytosis can also happen because of hemorrhage, congenital issues, drugs, certain drugs. So there are some common factors attributed to increased and decreased conditions of the size. Mostly due to heavy metal poisoning hormonal deficiencies, diet deficiencies, iron deficiencies, and some cold agglutination conditions. What are cold agglutination conditions means? Do you remember? What are cold agglutinins? Rolex formation. Any more specific? What are cold agglutinin conditions? Bone marrow failure can result in these issues, size issues. Listen, cold agglutination means, do I say this one? RBCs will be sensitized by our own antibodies. RBCs will be sensitized by our own antibodies, resulting in destruction of our RBC. Is it possible that our antibodies will target our own RBCs? Is it possible? In some conditions, our antibodies will target our own cells and they will destroy the cells. Okay. Now listen, RBC antibodies coated on the RBC, but RBC not destroyed. Got it? RBC was sensitized by antibodies, but RBC didn't destroy. Such condition is called as sensitization. Or such antibodies are also called as cold agglutinins. Cold agglutinins. Now listen, to these patients, if they catch some infection such as staphylococcal infection, if these patients get any staphylococcal infection, body will create some staphylococcal antibodies. Okay. Now staphylococcal antibodies can able to trigger. They will bind to this second primary antibodies and they will destroy the RBC. Such condition is called as cold agglutinins. Okay, this will be understood well in immunology. Right now you just remember some antibodies will coat RBC, that is called as cold agglutinin condition. This can also be seen in mismatched blood transfusion. This phenomenon can be seen in mismatched blood transfusion. They have A group and she has B group, you give her the blood. Now this can happen. And other condition is erythroblastosis precocis. Erythroblastosis precocis, I hope you know. A pregnant woman with a negative group but a positive filters, first time no issues but she will be sensitized. Second time baby will be destroyed because of agglutination. Okay. Such condition is called as erythroblastosis precocis. Okay. So all these things are related to size issues and shape issues. Then we discussed about the inclusion bodies. What are inclusion bodies means? Presence of some residual particles within the RBC are called as inclusion bodies. Can you give some examples of inclusion bodies? Yeah. One is Hen's bodies. Hen's bodies are seen in G6PD deficiency, very good. Then Coagulation bodies. Coagulation bodies are seen in post-splenectomy. Then in microplastic anemia you will see Coagulation bodies. Then any other bodies? Basophilic striplings. Basophilic striplings are seen in thalassemia. Basophilic striplings are seen in thalassemia. And of course in malarial infection you will see malarial parasites inside the RBC. Okay. So these are the some areas inclusion bodies in the RBC. Okay? So that's it. This is all about RBC abnormalities. Then next topic. What topic we can discuss? Hemostasis. Yes. All right. So coming to the hemostasis. Hemostasis. Okay. So what is hemostasis means? Mechanism of prevention of bleeding, and its removal is called as hemostasis. Okay. Removal of clots are called as hemostasis. Then hemostasis starts with what? Yes, blood vessel damage. So there is blood vessel and it is damaged. Okay, something has been penetrated. Now, damaged blood vessel, what happens? Collagen will be exposed. Collagen has been exposed. Now, Endothelial cells will secrete 1 milligram factor. 1 milligram factor will be secreted by endothelial cells. Next. Yes. Platelets will get attachment of platelets. So what are the three properties of platelets? Attachment of platelets, aggregation of platelets and activation of platelets. Very good. Now, this endothelial cells also secretes, endothelial cells and platelets together will secrete one more hormone. What is it? Actually, that's a serotonin. Okay, what is the role of serotonin? Vasoconstriction. So the blood vessel diameter will be decreased. Vasoconstriction happens simultaneously. Then, now this attached platelet will release what? Attached platelet will release what? ADPL, thromboxane A2. Also, this platelet will release one more self-activating cytokine. What is it? Platelet activating factor. Okay. So together these things will enhance the aggregation of platelets. So many platelets will bind to the site of injury. Now they will make what is this called as primary platelet plug formation. After primary platelet plug formation, what happens now? These platelets will get activated. So first attached, aggregated, then platelets will get activated. Activated platelets will convert fibrinogen to fibrin, and fibrin results in clotting of blood. Okay. Now, in the 1 milligram factor, one more clotting factor will associate with 1 milligram factor. What is it? Factor, clotting factor A. Very good. So this is all about hemostasis. The same phenomenon we will show in flow chart. So let us tell the steps in flow chart. What are the steps? So first, blood vessel damage plus exposure of collagen fibers. Then attachment of platelets in the presence of 1 milligram factor. Okay. Then after platelet attachment, what happened? Activation of platelets. Activation of platelets. Now activated platelets will do three things. What are those? Secretion of serotonin. Secretion of thromboxane A2 plus ADP. In the presence of platelet activating factor, they will do primary aggregation of platelets, aggregation of platelets, then primary plug formation. Then secretion of serotonin results in vasoconstriction. Then what is the third step? Activation of platelets. Activated platelets will result in clotting of blood. Okay, to be precise, fibrin to fibrin will be polymerized to become a clot. Okay. Then what is the last and final step of fibrinolytic mechanism? This is all about this one. Okay, hemostasis. If I ask this question, you must write this flowchart. This flowchart along with a diagram, if possible. Okay, a diagram should be drawn with plasters. I mean crayons or colors. Okay. Yes. Factor 8. Listen, factor 8 is a combined form of 1 milligram factor 8. That's why factor 8 is not secreted by liver. If you see all clotting factors, only factor 8 is not secreted by liver. It is secreted by endothelial cells of the blood vessel. Yes. No, it's a complex. Clotting factor 8 will present and 1 milligram factor. Together they are present. Always 1 milligram factor is in association with factor 8. Sometimes factor 8 will be deficient. Results in hemophilia A. That's why factor 8 is called as anti-hemophilia. Do you remember? Alright. So this is all about the hemostasis. Next we will discuss about clotting factors. Let me erase it. I hope clotting mechanism also you know very well. And I will do a quick revision. Yes. Coming to the coagulation mechanism. So we have what are the three pathways?
Intrinsic,
Yes. Intrinsic pathway,
extrinsic, or common.
extrinsic, then
Common.
common pathway. So there is common pathway. There is a production of one actuator. What is that? Prothrombin actuator. So prothrombin actuator will convert prothrombin to thrombin. Then thrombin will be converted. Thrombin will convert fibrinogen to fibrin, and fibrin will cause clot. Right? This is it. Now, yes. Now, extrinsic, yes. Alright. So, extrinsic common issues can be detected by
Extrinsic or
common. Extrinsic common can be detected by what lab test? Prothrombin type. Intrinsic common by APTT or APTTK. Then fibrinogen to fibrin conversion can be seen by thrombin type. Then overall efficiency can be detected by TGT. Then there is one more thing. Person to person, we will standardize the values, and that is called as INR. We are also performing one more test called INR. Okay. Now, what clotting factors are vitamin K dependent? 7, 10, 2. Okay, 10, 9, 2, 1. Not 1. Only 2. 7, 10, 9, 2 are vitamin K dependent clotting factors. Got it? So that means, just imagine, vitamin K deficiency results in what lab test elevation? Assume patient has vitamin D deficient, vitamin K deficiency. Vitamin K is deficient in patient. What will be the value of PT? Is it normal or increased or decreased?
Decrease.
Nothing. It will increase. Okay, PT will increase. Why?
Activation
Yes, clotting factor 7 present in extrinsic. Okay, extrinsic and common. So PT will increase in this one. Okay. Then what about APTT? APTT. What factors are there in APTT?
Last one is 2 or
No, 2 and 1 are common pathway. 2 and 1 are common pathway. Prothrombin and fibrinogen are 2 and 1. I understood. Okay, you came in that. Fine. So either it will be normal, it will be slightly increased. It will be slightly increased. Then that's it. In afibrinogenemia, what is afibrinogenemia means? Absence of fibrinogen. In afibrinogenemia, what will be the results of all these things? PT, APTT, TT and TGT.
Increase over
TT will be drastically increased. PT will be, moderately they will increase, whereas TT will be drastically increased in afibrinogenemia because there is no fibrinogen. Okay, and overall TGT will also drastically increase. Okay, this will be the results of afibrinogenemia. Okay, then what is the significance of bleeding time and clotting time? What is the significance of bleeding time? Yeah. Simple. Give me a straight answer, not significance. What is the cause of increased bleeding time? Cause of increased bleeding time. Thrombocytopenia. Thrombocytopenia. Any other conditions of increased bleeding time? Very good. 1 milligram factor disease can result in increased bleeding time. Any more? What will be the case in case of hemophilia A? Hemophilia A means that is a factor 8 deficiency. What will be bleeding time in factor 8 deficiency? Will it increase or it will stay quiet? Bleeding time will increase even though it is a clotting factor, but that is contributing in blood vessel damage, blood vessel repair. So hemophilia A will result in increased bleeding time. Okay. Then hemophilia B, clotting time will increase. In B, clotting time will increase. Got it? Any others? What conditions results in clotting time increasement? Hemophilia, yes, one condition is hemophilia. Then 1 milligram is no. Listen, 1 milligram only contributes in bleeding issues, not in clotting. We don't have any role in clotting mechanism. Okay. Yes, should be. Thrombosis. Very good. Everyone clap for should be. Thrombosis. What is thrombosis means? Excessive activation of platelets within the blood vessels results in clotting, excessive clotting. Okay. Great. Yes, should be. You made a mistake. In thrombosis, clotting time might increase, it won't increase. Got it? There is an excessive clotting in thrombosis. I am asking about increased conditions. Any others? Obviously, vitamin K deficiency. Any other conditions? Malnutrition. Okay, diet will have K. If you have malnutrition, no K, no vitamin K. That results in absence of this. Any more? Warfarin therapy I will doing. Warfarin therapy. If patient is in any anticoagulant therapy, then clotting time will increase. Any more? Absence of clotting factors. Absence of clotting factors can result in increased clotting time. Any more? Any more interesting cases? Liver disorders. Liver disorders then leads to increased clotting time. Okay. Yeah. So these are the conditions of increased clotting time and bleeding time, coagulation mechanism, hemostasis, and all these things. Is it clear? Yes. Next we will discuss about fibrinolytic mechanism. Whomsoever not paying attention to this class, they are the one who is getting less marks in MSTs. That is the stone cold truth. Anyway, that is not my problem. You are paying 50,000, I am not, right? Every month I will get my salary. I don't have any issues. Yes, next. Fibrinolytic mechanism. Keep in mind, you are not rich. Keep in mind. You are the poorest fellows right now. You are just living on the support of your parents. Be serious, okay? You are the garibest garibs. Yeah. Yes. Don't think you are smart. Okay, fibrinolytic mechanism. So what is fibrinolytic mechanism?
Discord in 1893.
What?
Discord in 1893.
Discord in 1893. Okay. Fine, good. Okay. Remove the fibrin clot. This called as fibrinolytic mechanism. Our sugar is very smart, very good. So, okay. How it starts? Yes. Tell me about this one. There is a scissor in the fibrinolytic mechanism. What is the scissor name? Plasmin. So there is a scissor called plasmin, and there is one enemy also. Enemies and heroes. Alright. So scissor is the plasmin. So how to make this plasmin is the story. How to make this scissor is the story of this one. So yeah. Let me write here. Plasmin. Production of plasmin is the this one. Okay. Idea is how to draw scissor like this, right? So plasmin is the scissor, and we need to create this scissor. And what plasmin will do? Plasmin will destroy the fibrin clot. It will destroy the fibrin clot, right? Let me see this. Okay. So plasmin will remove the fibrin clot. So how to make this plasmin? Plasmin is present in the body in the form of inactive form. That is called as plasminogen. So plasminogen will be converted to plasmin, and it will cleave the fibrin. So what is the component that is responsible for activation of plasminogen? Yeah, that is called as TPA. What is the full form of TPA? Tissue plasminogen activator. This tissue plasminogen activator will convert plasminogen to plasmin. Along with there is one more which is called as directly TPA, plasminogen activator. Yeah, tissue TPA. Okay. Now, how to synthesize TPA? TPA can be synthesized by two mechanisms. What are those? Yeah. So let us see here. Whenever there is a tissue damage, blood vessel damage, damaged blood vessel will release thrombomodulin. Thrombomodulin plus thrombin. Okay. Thrombomodulin and thrombin will make a thrombomodulin-thrombin complex. Okay. This complex will convert protein C to activated protein C. This activated protein C combined with factor 5 and 8 and will activate the tissue plasminogen activator, or there is a direct mechanism. This also inhibits TPA. Inhibits a TPA inhibitor. TPA inhibitor will be inhibited, so it will be activated, or it also combines with factor 5 and 8 and it will be activated to make this one. Lysozyme will be directly, Lysozyme can directly activate tissue plasminogen activator, and it can do this one. And that's it, right? This is all about the fibrinolytic mechanism. Just this flowchart is sufficient to explain the answer to the question. Okay? Draw this flowchart and start explaining this one. A damaged blood vessel will release these, and this will convert C to activator C. Activator C will make this activator, and activator will activates Gen 2 plasmin, and plasmin will cut the thrombins. Okay, this is it. This is all about the fibrinolytic mechanism. What clotting factor is inorganic in status? Is inorganic in state? Which clotting factor is inorganic? It is not an organic molecule. Everyone clap for Muskan. Calcium. Calcium is inorganic substance, right? So removal of calcium from the blood is called as chelation. Chelation can be achieved by what components? EDTA. Very good. Oxalates can also do chelation. Okay. Very good. Then what are the natural anticoagulants? No, we cannot say warfarin as natural. Warfarin is an oral. Okay. Natural anticoagulant is heparin. Very good. What is the mode of action of heparin? Based on state what since she know that. Yes, it is an antithrombin. Okay. Actually I didn't say this fibrinolytic mechanism, there is something called antithrombin 3. Okay, there is an involvement of antithrombin 3. Antithrombin 3 will be useful in clotting mechanism. Anyway, that we'll see later. This is a very big mechanism. Okay, you just remember there is a component called antithrombin 3. Heparin will inhibit antithrombin. Okay, yeah. So antithrombin 3 is an anti-heparin. Huh? Thrombosis? Exam. Yes. If there is any, excessive clotting leads to thrombosis. Excessive clotting disorders are a type of thrombosis. That means blood will be clotted and clotted blood will block in the blood vessels. That condition is called as thrombosis. Okay, that's it. Inhibition of coagulation. Listen, inhibition of coagulation will be these things. These things are always inhibiting not to clot the blood inside the circulation when it is in circulation. Actually, okay. Inhibition of coagulation or fibrinolytic mechanism is same. You got it right? Because inhibition of coagulation, we are removing the clotting things. Okay. As I stated previously, do you remember or not? Damaged blood vessel triggering to clot the blood. Damaged blood vessel also triggering to remove the clotted blood by thrombobodyling. And that's very interesting pathways. Yeah. Alright. Of course, there are a few more things like high molecular weight kininogen. You can go through textbook material, right? There are some more molecules, high molecular weight kininogen, etc. Alright. Okay. Okay.